Welcome everyone for the class on gastroenterology. So we'll be discussing about gastroenterology and also we'll be discussing about hepatology. So we'll be discussing about gallbladder and the hepatic tree. We'll also be discussing along with the gastroenterology. First thing very important in gastroenterology is upper GI bleed. Okay, they tend to ask one question from the upper GI bleed in every diet. First, let's see what are the causes for upper GI bleed. As you can see, there are various causes. The important one is peptic ulcer disease and varices. Varices usually happens because of portal hypertension. Okay, we'll talk about this extensively in coming up slides. Other causes, they might be because of malignancy or might be because of any clotting disorders, any tumors, any congenital abnormalities, or any inflation like esophagitis or duodenitis or and gastritis. So different causes, we are mainly worried about peptic ulcer disease and esophageal varices. These are the most common disorders which will cause upper GI bleed. What are the causes for ulcers? First most common cause for an peptic ulcer, that is either in your duodenum or in your stomach, is because of H. pylori. The second most commonest cause for ulcers are NSAIDs. Variceal hemorrhage. What happens whenever there is a chronic liver disease? The junction between the portal and systemic venous system is known as varices. Those veins gets dilated because there is a lot of pressure in this junction, which is known as portal hypertension, which leads to dilatation of these veins known as varices. This varices directly correlates with the severity of the underlying disease, that is underlying liver disease. So underlying liver disease severity can be classified within classification known as Child-Taught classification. If you just remember the name, that should be sufficient. It's not important to remember the classification or how do they classify the liver grading and disease, how severe is the liver disease. The classification or the grading is not required from emergency point of view. You can just remember it correlates with the severity of the underlying liver disease. Underlying liver disease. So if a patient is present to the emergency department has an upper GI bleed, what we do? We always get a scoring done, that is Blackford score. Blackford score is again very important part of upper GI bleed. This scoring is done because if they don't have any one of the following, then you can discharge them safely. If any one of the following is there, they require admission. Sometimes they might require immediate endoscopy. Sometimes after admission, electively, they can get an endoscopy done. So what are the different components? It's important to remember the different components from this score, what we are given here. That is blood urea, hemoglobin, which changes for both male and female, systolic blood pressure, heart rate, presentation with melena or syncope, any liver disorders, cardiac failure. So you need to remember the components of this. It's not important to remember the score because scoring is difficult. The components you can easily remember. Remember the components. They'll just test you on the components, not on the scoring. So you need to remember urea, hemoglobin, systolic blood pressure, heart rate, presentation with melena or presentation with a syncope, any liver disorders, heart failure. There is one more scoring known as Rockall scoring. In Rockall scoring, these two things what you have given here, this is the same thing given here also. That means for this source of bleeding and stigma of recent bleeding, you will come to know only after endoscopy. It's an endoscopic diagnosis what you are having. Rest of the variables can be found out from the initial presentation to the ED itself. On examination, you can find out, and with the history what you're taking, you can get this top 3 columns what I mentioned here. But for the source of bleeding and stigma of recent bleeding, you need to get an endoscopy done. So for a complete Rockall scoring, endoscopy is a must. So that's the reason we don't use it, or it's not preferred to use it in the emergency department, because we don't always get an endoscopy done. So, and the scoring requires an endoscopy. For us, much more important is Blackford scoring. So it is not important to remember Rockall scoring. It's important to remember Rockall scoring requires both pre-endoscopic and endoscopic for doing a complete score. What are the investigations which are required? This person is bleeding. So if he's bleeding, he might require a blood transfusion. If he's bleeding, he might be anemic. He might have lost a lot of blood, resulting in low hemoglobin levels. So you need to get a full blood count done. Clotting profile, you need to get it done so that it will help you with massive hemorrhage protocol. To transfuse blood, you need to know the blood group and get the blood cross matched. LFT is required because chronic liver diseases or any liver diseases leads to varices. We know that in liver diseases, liver function test will get dearranged. Urea and electrolytes are also required. Because of GI hemorrhage, there might be electrolyte imbalance which can occur. Chest X-ray, for example, they might have aspirated. The important thing, what we keep forgetting is if we keep vomiting, the GCS will come down because of drastic reduction in the hemoglobin level. So hypoxic encephalopathy will occur. Once the GCS comes down, there is possibility of aspiration. Because he is vomiting, there is possibility of aspiration. That's the reason X-rays are important. So what's the treatment? So we as emergency physician will always go airway and breathing. First, if anything is compromised here, you'll intervene. Then comes to circulation. There is a bleeding which is happening. There is a hemorrhage which is happening. If compromised, that means he's not hemodynamically stable, suggested by a high heart rate or a low blood pressure or a high CRT, then start resuscitating. What is the best fluid to resuscitate? Blood transfusion is the best method to resuscitate. If you don't have blood immediately available, or from exam point of view, in the options, they have not mentioned the blood, then start with IV fluids. It's always a good habit to start massive hemorrhage protocol if the patient is hemodynamically unstable. Once you have started resuscitation, the next step is to give telepressin. This we are talking about variceal bleed only. So telepressin is known to reduce the morbidity and mortality in patients with variceal upper GI bleed. Okay, this is very important, known to reduce both morbidity and mortality. Simply, we call it as reduction in MNM. And also give antibiotic. Preferred antibiotic is either third generation cephalosporins like ceftriaxone, cefotazime, or you can use ciprofloxacin, which is a quinolone. Why do we give antibiotics? Because your stomach is an unsterile place because you're eating food particles. Food particles are not sterile. There is an opening in the vessels because these vesicles, these vesicles which are there at this junction, they usually get ruptured. So food particles can enter into your bloodstream and cause infection. Most of them end up dying because of infection. That's the reason we start them on antibiotics, which most of the people forget. Then if still ongoing bleeding is there, you need to stop this bleeding. Best way to stop it by banding. How do you band it? By doing an endoscopy. So involve the gastroenterologist, so an endoscopy can be done. Endoscopy is basically a camera passed via your oral cavity into your stomach to see where is the bleeding spots. Junction of esophagus and stomach usually will be the varices here, and they will do the banding and stop the bleeding. For some reason, if you don't have the gastroenterologist available at the right time, or the endoscopy what you have done is failed, then you can do something known as balloon tamponade. Okay, what is balloon tamponade? Balloon tamponade is nothing but zinc taken black mold tube. This is a tube which you insert through your nasal or the oral cavity and goes inside in your stomach. There's a one bulb which inflates in the esophagus, another bulb inflates in the gastric, that is in the stomach. Inflation of these balloons will cause compression of the vesicles and it might stop the bleeding. It will just help you to buy time. Till then you can plan the next step. Next step will be either usually a stent or TIPS, that is transjugular intrahepatic portosystemic stent placement. So how will be the question comes? People usually get confused with the treatment part, and extensive questions will be asked on the treatment part. So how to answer them? We go in a systemic manner. First, from the stem of the question, you'll see whether they have mentioned a liver disease, alcoholic disease, or they are directly mentioned as a variceal bleed. If yes, then you're following this treatment algorithm. First, airway and breathing. If it's compromised, you will secure it. Then go ahead and see the circulation. If they are not hemodynamically stable, first start on either fluids or bloods. Blood is preferred over the fluids. The next step is giving telepressin. along with antibiotic, but giving telepressin is the most important because it reduces morbidity and mortality. Next step will be to involve the gastroenterologist to get an endoscopy done for banding purpose. If endoscopy fails or you're not able to get an endoscopy immediately done because gastroenterologist is not there, he's on leave, or for any reason, you can go ahead with balloon tamponade. It just buys the time. Then you will be going with the next step, that will be the either esophageal stent or tips. Again, you are not much involved. You are involving gastroenterologist. Usually they'll be testing this till here. They'll be testing, unlikely to go ahead at this part, What about if the bleeding is because of the ulcers? Two important causes. Initially, I told you either it will be visceral bleed or because of an ulcer. How do you know it's an ulcer disease? Either he is a known case of ulcer or previous history of H. pylori infection or an NSID or any other cause of bleeding also, any other extensive causes like gastritis, esophagitis, any other causes, there are Leonitis or a big cause of malignancy, still you can follow this algorithm. Same way as in emergency vision, we'll go with airway breathing, then we'll be going with circulation. If compromised, that is high heart rate, low blood pressure, and high CRT levels, then we'll give either blood or IV fluids. Blood is preferred over IV fluids. Next step will be directly going ahead with the endoscopy here. There are no drugs other than in visceral bleed, which is causing upper GI bleed. Any other cause, there is no drug which will reduce the morbidity or mortality. Here we'll be going ahead with endoscopy. Endoscopically, they might do they might stop the bleeding using the adrenaline or thermal coagulation with adrenaline. Is their headache, they'll not test you on this. For endoscopy, you need to involve gastroenterologist. That is where they will test you, the importance of it. If this endoscopy fails or you want to buy time because gastroenterologist is not there, then you can try balloon tamponade as explained previously. If endoscopy doesn't work, the next best method is radiological embolization or surgical intervention you might have to do. What about proton pump inhibitors, especially the omeprazole? Omeprazole, can we give it? Because it's extensively given in most of the countries. Is it preferred to give it, or is it recommended to give it? What's the guidelines suggest you all about here? The guidelines suggest that avoid acutely unless known case of peptic ulcer disease. If he is a known case of peptic ulcer disease, then give omeprazole IV, you can give 40 mg. Or you can start on the infusion. Also 8 mg per hour, you can start the infusion. If he is not a known case of peptic ulcer disease, then don't give him PPI. They're not known to be helpful in any way. If he's only known case of you, if you're only suspecting also, don't give omeprazole. If he's a known case, then only give omeprazole 40 mg, it's preferred. So let's go step by step. First airway and breathing, then in circulation. If you're not compromised, then you're going for IV fluids or blood transfusion. Next step will be get an endoscopy done. If endoscopy fails or some other reasons, you can do a balloon tamponade. You will just buy the time here. The next step will be radiological embolization. PPI are only recommended if he is a known case of peptic ulcer disease. Otherwise, do not give PPIs. Preferred PPI is omeprazole over any other. There are plenty of other PPIs like pantoprazole is there, rabiprazole is there, so esomeprazole is there. Preferred one is omeprazole. What about lower GI bleed? Lower GI bleed is a low ill topic because we rarely see any lower GI bleeds. Most of the time, this lower GI bleed patients will be stable. It's an upper GI bleed which causes hemodynamic compromise. What are the causes for lower GI bleed? It can be a diverticulitis, is the most commonest cause, or it can be ischemic colitis or hemorrhoids or inflammatory bowel diseases, especially the Crohn's disease you're talking about here, or any CA colon especially, or any radiational enteropathy has caused. Angiodysplasia also can cause. The important ones are diverticulitis, inflammatory bowel disease, and cancer here. Investigations are very much similar to that what we previously discussed. The additional one is blood or stool cultures might be required because it might just be an dysentery. It may not be an obvious lower GI bleed. What about the treatment of lower GI bleed? Again, we'll go according to airway, breathing, circulation. This too remains the same as we discussed previously. Okay. If the patient is unstable, you're directly going ahead with colonoscopy and radiological embolization. One of the following you can do, or it is, okay, either colonoscopy you can do or radiological embolization you can do. Okay. For radiological embolization, you need to get an CT angiography done. For colonoscopy, you can directly do it colonoscopy, but if it's a gross bleeding, while they place a camera inside your bowels, they may not be able to visualize because of heavy bleeding. If there is a heavy bleeding, then radiological embolization will be a better method, because CT angiogram will show the culprit artery where it is bleeding from. Then they can embolize that particular artery. If it's a stable patient, you will go ahead and admit for colonoscopy. Similarly, in an upper GI bleed, if the patient is stable, then what you will be doing is you will go ahead and admit that and get it endoscopy done from an ward or from an wherever you're admitting. From there, you can get an endoscopy done. It's not required to immediately get it done if the patient is hemodynamically stable. When can you discharge patients with and lower GI bleed? Here we are talking about lower GI bleed. Upper GI bleed, we know there is a scoring. If the score is 0, we can discharge. In lower GI bleed, if the patient is a young individual, hemodynamically stable, no evidence of gross rectal bleed. There is no evidence of hematochezia, that is gross rectal bleed. Does not take any anticoagulants or non-steroidal anti-inflammatory drugs. If he's not taking any one of these drugs, he's hemodynamically stable, he's a young individual, less than 60 years, there's no gross bleeding from rectum, then you can discharge these patients. So this covers the upper and lower GI bleed. Anyone has any questions, you can ask me now before we go ahead into vomiting.
Assalamu alaikum, Dr. Ameen.
Walaikum salam.
In differentiation between in upper GIT bleeding, to differentiate it between variceal and peptic ulcer bleeding, this depends on the history.
Yes, it will depend on the history, because here in upper GI bleed, he'll be vomiting out. Okay, he'll not be presenting a fresh blood from the rectum. A fresh blood from the rectum, you should always think of a lower GI bleed, unless it's in melena. Melena is black colored stools. It can be, or most of the time, it will be an upper GI bleed if it's melena. Melena is nothing but black color stools. If you're seeing in black color stools, always suspect first an upper GI bleed. Once you're ruled out upper GI bleed, then you can think of lower GI bleed. Otherwise, the history will be very classical. He's vomiting blood, then upper GI bleed shouldn't be a problem. Gross bleeding from the rectum, then it will be a lower GI bleed. Melena is the only thing where black color stools, if they say, always think upper GI bleed first, followed by lower GI bleed.
So any discharge criteria for upper GI bleeding?
Yes, it's a very important one, which we have already discussed. This is the discharge criteria. If the patient scores 0, then you'll be discharging.
Sure. Thanks. I missed that. Thank you.
Yeah. We'll go with the vomiting here. So as you can see, there is various causes for vomiting. It can be because of GI or CNS systems, endocrine system, pregnancy, various drugs can trigger vomiting. Vomiting is reverse peristalsis. Food is supposed to go through the esophagus in the peristaltic movement. Okay, constriction happens, it goes in peristalsis. If there is a reverse peristalsis, it comes out through the mouth and you tend to vomit. Various causes, as I said, it can be because of any acute abdominal conditions like pancreatitis, cholecystitis, appendicitis, or gastroenteritis, intolerance to the food, CNS symptoms, especially when there is an increased intracranial pressure, or because of vertigo, motion sickness also. Endocrine, especially like a patient with diabetic ketoacidosis, hyperglycemia you're talking about. Pregnancy, morning sickness, when it becomes very bad, then we call it as an hyperemesis gravidarum. Or drugs like alcohol, opiates, chemotherapy, they can trigger vomiting. Okay, what are the antiemetics? What are the options what we have? Antiemetics like chlorpromazine can be used. It's very much helpful in vertigo. It is used in vertigo as an IM injection. Okay, it blocks the receptors at CTZ, that is chemoreceptor trigger zone. Prokinetics, that increases the motility of the GI tract. Metoclopramide and domperidone, the main difference is domperidone doesn't cross the blood-brain barrier. BBB, we call it, stands for blood-brain barrier. That means it doesn't affect the brain, or it doesn't go into the brain. Metoclopramide crosses the blood-brain barrier. It is important because metoclopramide is prone to cause acute dystonia. This will be discussing more in coming up chapters. But remember, metoclopramide is known to cause acute dystonia. The incidences are much lesser in domperidone because it doesn't cross blood-brain barrier. As it increases the GI mobility, you can use it in patients who is having reflux, okay, or who is having gastric paresis. In these patients, it will be much more helpful. Antihistamines like cyclizine is very useful in vertigo as well as motion sickness. It acts on vestibular system, that's why it becomes very helpful. The last one, the most important one, is ondansetron, which is most commonly used worldwide, has least side effects compared to all other antiemetics. It acts on 5-HT3 receptor centrally along with chemoreceptor trigger zone. The main thing you need to remember here is where it acts. And it is the drug of choice for chemotherapy. Whenever they are on chemotherapy, if they are having nausea and vomiting, they always prefer giving ondansetron. Ondansetron acts on 5-HT3 receptors. As an antagonist, you need to remember this. As an antagonist, it acts on 5-HT3 receptors. What is Broha's syndrome? Broha's syndrome, before we go ahead with the Broha's syndrome, we need to understand what is Mallory-Weiss syndrome. When you're vomiting multiple times, what will happen because of retching, because of forceful movement of the food particles, and if you're vomiting multiple times, there's a scraping of inner lining of the esophagus, which will cause bleeding. Usually it will not be medically significant bleeding this patient will have. Classical history will binge drinking, which is causing vomiting, multiple episodes. First few episodes, there will be no blood at all. After few episodes, they start noticing blood. That is because in first few episodes, it's just scraping. Once the scraping is done, it started bleeding. So the mucosal membrane is damaged, started bleeding. That's when you see bleeding. But the outer layer is quite intact. As you see in this pic, the outer layer is intact. What is Broha's syndrome? In Broha's syndrome, there is complete rupture of the esophagus. Rupture of the esophagus occurs when there is a drastic and acute increase in intraesophageal pressure. As it ruptures, there is a certain amount of air in the esophagus which gets leaked. Along with it, it is bleeding. Because this air is getting leaked outside, it causes subcutaneous emphysema. In the mediastinal region, you see the subcutaneous emphysema. Sometimes it can pass on, and you can see on one side there is a subcutaneous emphysema. Okay, when you palpate, you can have a crunching sound also. So if you get an X-ray done, the most important thing what you're looking out for is subcutaneous emphysema. This is the subcutaneous emphysema what you're seeing, because this is an air-filled cavity. Along with the air-filled cavity, there are also food particles. Food particles, as I told you, are not sterile. They can cause infection. It has ruptured, and in the sterile space, that is in mediastinum, the food particles have gone in, so it can cause infection. So one of the important treatment here is broad spectrum antibiotics. You can't do anything where it is ruptured. You need to involve cardiothoracic surgeons where they have to open the chest and fix the esophagus what has been ruptured. What's the management for Mallory-Weiss syndrome? The management for Mallory-Weiss syndrome is nothing. It's just symptomatic treatment. Okay, it will heal on itself. Don't worry. If you're taking alcohol, don't take alcohol. I'll give some antiemetics so that your vomiting subsides. You should be fine. What is cannabinoid hyperemesis syndrome? Okay, here what happens is whenever they consume cannabis, that will trigger vomiting. Usually they'll have cyclical episodes of vomiting. They will usually come saying that whenever I take hot shower, I'll feel better. But again, it starts vomiting. It's a cyclical, continuous vomiting. Every few minutes, I'm vomiting. If they agree they are taking cannabis, on cessation of cannabis, they feel better. Okay, this is termed as cannabinoid hyperemesis syndrome. The only thing what you can do is tell them to stop cannabis consumption. It will come down on itself. There is another term, usually it comes up in options, so that you will be aware now how to rule it out. Eosinophilic esophagitis. When eosinophil counts are more than 15 on microscopy of an esophageal biopsy, then we call it as an eosinophilic esophagitis. It is very rarely seen. Sometimes it comes up in the options. You get confused. It's the reason we have put up to know what exactly it is. It's not an emergency medicine diagnosis, or it's not an ED made diagnosis, because esophageal biopsy needs to be taken, which is not done in the emergency department. Coming up to diarrhea. What's the definition of diarrhea? If you're opening your bowels more than 3 times in a day, or the quantity of the motion what you have passed is more than 200 grams per day, then we call it as an diarrhea. This patient is having a diarrhea. If this diarrhea is lasting less than 4 weeks, then it is an acute. More than 4 weeks, then we call it as a chronic diarrhea. What are the causes of diarrhea? We all know infection can cause. Along with the infection, there are other symptoms also, like ischemic colitis, malabsorption, irritable bowel syndrome, inflammatory bowel syndromes, inflammation of appendix, pancreas, or diverticula. Certain drugs can trigger diarrhea, like metoclopramide. Certain drugs like metronidazole itself can cause diarrhea. Some antibiotics, especially coamoxiclav, can trigger diarrhea. So there are plenty of drugs. The infection is important for us because we might have to start the antibiotics in them. Okay, so the question they can give you and ask you which organism it might be causing, or what complication you are expecting in bloody diarrhea. So what is bloody diarrhea? Bloody diarrhea is nothing but dysentery this patient is having, or simple diarrhea. Let's first see about bloody diarrhea. What are the causes? What are the organisms? How to pick it up from the stem of the question. Campylobacter jejuni. Whenever they are testing about this, they're testing about Guillain-Barré syndrome. Okay, they're testing about this. It's a fecal-oral transmission this one is having. E. coli. There are different kinds of E. coli. Okay, one is O157H7. It is known to cause HUS, that is hemolytic uremic syndrome. Another one is enterotoxigenic, that is nothing but traveler's diarrhea. Okay. Salmonella is commonly seen because of consumption of undercooked chicken or eggs. Usually it spreads by having eggs or chicken, and usually they kind of discard the complete batch itself. Yersinia, whenever there is in rodent urine or feces or old creamy pastry cakes they are having, pastries they are having, it can cause this one. Giardia, usually they go for trucking and have fresh water, results in symptoms which are fat malabsorption. And amoeba histolytica, commonly seen in persons who travel to an endemic area where there is endemic for amoeba histolytica. What about non-bloody diarrhea? Viral gastroenteritis. Rotavirus is commonly seen in daycare settings. In children who go for daycare, rotavirus is commonly seen. Norwalk virus is commonly seen in cruise ship. In cruise ship, usually it will be like an outbreak where everyone who is there in the cruise ship ends up having gastroenteritis. Most commonly, it will be because of norovirus. Staphylococcal aureus is mainly having creamy foods like mayonnaise, the white color paste which is extensively used in most of the sandwiches. Having this results in diarrhea which is non-bloody caused by Staphylococcal aureus. Usually after 6 hours of consumption, they tend to start with an diarrhea. Bacillus cereus, refried rice. Refried rice, when do you see an refried rice? Especially when they are baking fried rice, the Chinese dish, the fried rice, usually they cook the rice and they refry it to add some more ingredients in it. This is known as refried rice. It's known to cause Bacillus cereus. Scombite food poisoning we'll again discuss in the chapter of dermatology, because it produces a rash which is very much similar to urticaria. But here there is an intake of seafood, especially the tuna or mahi-mahi fish. They're prone to cause cambriate food poisoning. There is a classical image which will show you in the dermatology chapter. Cryptosporidiosis is seen in immunocompromised person, especially in HIV positive. Whenever the CD4 counts are less than 100, always think of cryptosporidiosis. What about Vibrio parahemolyticus? It is seen or look for oyster eating in warm weather environment. Oysters when you are having. Vibrio vulnificus. This is eating raw seafood like sushi, more as Japanese food like sushi. They will present with skin blisters or liver lesions, mainly skin blisters, what you need to look out for. And having sushi, it's a Japanese dish, sushi. If they had this, then think of it might be Vibrio magnificus. This again, it can rarely come in the examination, not very high yield, because most of the time this patient ends up presenting to an GP rather presenting to an emergency department where they have to wait for hours together. This they can ask you, what's the indication for stool cultures and sensitivity? When do you get a stool culture done? When the patient is in sepsis, systemically unwell, along with the diarrhea, there is blood or pus in the stools. Any immunocompromised individual, if you're thinking, especially in HIV, if you're thinking, you need to think of cryptosporidiosis. That's the reason you are getting the cultures done. Any history of foreign travel other than the developed countries like Western Europe, North America, Australia, New Zealand, any other places or any other countries they have traveled to, always get a stool culture done. If there is a recent antibiotic use or an hospital admission, we are thinking of Clostridium difficile, get and culture done. Persistent diarrhea, which is lasting for more than 1 week, then you need to get it. This is not and chronic diarrhea, is a persistent diarrhea. Chronic diarrhea is more than 4 weeks. Treatment, most of the time we just hydrate them if they are dehydrated by giving IV fluids. If they're able to take orally, then we ask them to take orally, then we discharge. We usually don't start them on antibiotics. If you are starting on antibiotics, ciprofloxacin is the preferred antibiotic when you're thinking an infectious diarrhea. If any one of the following here, which are present, like especially E. coli or Giardia you are thinking about, you can start on ciprofloxacin. Probiotics you can prescribe to everyone. They are helpful. There's no harm in prescribing probiotics. PPIs, which stands for proton pump inhibitors, there is no use at all. Don't use it. Loperamide, symptomatically, it will be helpful. Recommendations are don't prescribe it unless it's absolutely necessary. When is it absolutely necessary? When the patient is not able to carry out his regular activity because every 10 minutes he has to go for a loo, then you will be starting on loperamide. Otherwise, don't start on loperamide. Do not advise them to take any caffeine. If they're taking caffeine in the form of coffee or tea, tell them to avoid it. Tell them to avoid sorbitol also. That means sorbitol containing gums or any raw fruits, ask them to avoid it because it is prone to cause osmotic diarrhea. Caffeine we are avoiding because it increases the gastric mobility. Okay, that's why it will worsen the diarrhea. That's the reason we tell them to avoid it. When is the admission required? When this patient is having persistent vomiting, unable to take anything orally, if you discharge him, most likely he will turn out to be dehydrated severely, and then you might come in a shock. That's the reason if he's not able to retain anything inside, admit him so that at least you can give him IV fluids. Patients who presents in a shock itself because of diarrhea or severe dehydrated hears, which is suggestive of an tachycardia or hypotension, always admit those patients. Clostridium difficile. Clostridium difficile, the classical history, either it will be an hospital admission or there will be an recent antibiotic use. Most commonly, there will be an recent antibiotic use. Whenever there is a recent antibiotic use, you need to always suspect Clostridium difficile. Which are the most commonest antibiotics to cause Clostridium difficile infection diarrhea? Clindamycin is the most commonest, followed by quinones, cephalosporins, and penicillin. But remember that tetracycline is not associated with this. What is the investigation of choice? Clostridium difficile is there in our normal flora itself. If you get in stool culture, sometimes it can come falsely positive because it's there in the normal flora. What happens when you take the antibiotic? The normal gut flora is affected. Once normal gut flora is affected, Clostridium difficile will replicate rapidly, resulting in diarrhea. So cytotoxin assay is the best investigation for this. What is the treatment? Treatment, if the WBC counts are less than 15, you can treat it with vancomycin. This is orally, we are giving 125 mg, not required to remember the dosage. Vancomycin, you can give it. Fidaxomicin can be given if the WBC counts are more than 15. Again, you are giving per oral. Per oral acts better than IV because it needs to act at the GI tract level. Okay, it's not required to be in your bloodstream. It has to be in our gut. To be in your gut, if you take orally, they act much better. That's the reason we give them orally. Oral is the best method. Any questions you can ask me now regarding the diarrhea and the vomiting, what we talked about?
Sir, the coffee causes like GI motility to go down or GI motility to go up?
Coffee, any caffeine you're taking in any form, like an Red Bull drink or a coffee or a tea, will increase the GI motility. Once the GI motility is increased, your diarrhea also will increase.
Okay.
Okay, that's why we ask them to just avoid taking caffeine in any form. Like you are having a Pepsi or Coke also has caffeines, we tell them to avoid.
Doctor, the lobramide, it's contraindication صح to give in the patient with infectious diarrhea, صح?
The problem with the loperamide is it reduces the gut mobility. By reducing the gut mobility, the bacteria will not get washed out. It might replicate and it can cause severe infection. But again, if it's like every hour he's having 5 to 6 episodes, in that way, then you can take loperamide. That's the only place that it's recommended. Otherwise, it's best avoided because it can worsen the infection.
Dr. Amin, regarding metronidazole for diarrhea, is any role?
When you're thinking about parasitic infection, that's when you give it metronidazole. Like, for example, if it's because of Entamoeba histolytica or Giardia, you're thinking about metronidazole, you can start. Basically, parasitic infections we are thinking about. If you think it is because of parasitic infections, because there isn't travel to an endemic area where there is parasitic infection and this patient's bowels are mucus and they are foul smelling, think about parasitic infection, then you can start on metronidazole or tinidazole, those classification of drugs, those class of drugs. We'll go ahead with inflammatory bowel disease. Okay, inflammatory bowel disease can be an ulcerative colitis or an Crohn's disease. Okay, what's the difference between ulcerative colitis and Crohn's disease? This is a favorite question in the lab. Unlikely they test you in your MRChem exams, but it's important to understand the differences. Okay, it is kind of, ulcerative colitis is kind of restricted to large bowel, especially in the colon. It can be anywhere in the GI tract. It can be in your mouth, it can be in your large colon, or it can be in your duodenum. The inflammation usually is continuous. Okay, there is no patchiness. If the inflammation is progressing from rectum to sigmoid colon, it will be continuous. This can be in patches. One patch seen in rectum, another patch seen in oral cavity, another patch seen in ileum. So it can be anywhere in patches. Okay, it involves only the superficial layer, the upper line, the mucosal layer is involved in ulcerative colitis. The complete thickness of the colon is involved in the Crohn's disease. Important to remember, complete thickness is involved. Rectal bleed is not very commonly seen, but still can happen. Not commonly seen in Crohn's disease, is more commonly seen in ulcerative colitis. Inflammatory bowel disease is an HLA-B27. Okay, it is a group of disorders. So this inflammatory bowel disease can be associated with any of the extraintestinal signs of inflammatory bowel disease or HLA-B27 related diseases. Especially what you need to remember is the eyes, that is scleritis and uveitis, also known as acute iritis, ankylosing spondylosis. These are the commonest which they present with, especially the eye symptoms and ankylosing spondylitis, as we have seen in our previous chapter, that it can cause bamboo spine and it causes the bone to be brittle, and fractures are more common here. So inflammatory bowel disease, you need to remember, can be associated with other disorders like erythema nodosum, scleritis, uveitis, ankylosing spondylitis. At least this much you need to remember. These are the important extraintestinal signs of inflammatory bowel disease. What are the complications you've seen? Complications are less in ulcerative colitis compared to the Crohn's disease, because in Crohn's disease, complete thickness is involved. Complete thickness of the bowel wall is involved. Here, there is only the superficial layer, there is a mucus layer which is involved. Okay. Though it involves mucus layer, it can cause bowel perforation, it can cause toxic megacolon, it can cause cancer, it can cause colonic bleeding. With all this, it can also, in Crohn's disease, the additional thing what you need to remember is it can cause small bowel obstruction due to stricture formation. It can cause abscesses. Fistulas are very important. It can cause fistula between the bladder and the colon, bladder and the vagina, or perianal fistulas. Rectal hemorrhages also can occur in Crohn's disease. Complications are important. It's not important for you to remember how an ulcerative colitis comes in, because they would have already been diagnosed with an ulcerative colitis. They come to the emergency department with one of these complications. So you need to be aware of these complications in ulcerative colitis or Crohn's disease. Let's talk more about toxic megacolon. Toxic megacolon on an X-ray, if the transverse colon diameter is more than 6 centimeters, you need to assume it is a toxic megacolon. Usually, they will be associated, usual symptoms associated are tachycardia, fever, and hypertension. Okay. Sometimes there might be an raised WBC count, low hemoglobin level, and low albumin levels can also be seen. But important things you need to remember: tachycardia, fever, and hypotension. That means this patient will be systemically unwell. This patient is in shock. Usually toxic megacolon patients will be in shock, you need to remember. And when you get an X-ray done, this is this whole thing what I'm drawing here is the transverse colon. The transverse colon diameter will be more than 6 centimeters, what you need to remember for exam. What about treatment? Treatment here is mainly IV fluid resuscitation if the patient has presented the shock. Steroid remains the mainstay, but nice recommendations are only use steroids on gastroenterology team advice. Okay, if they don't advise, don't give it. If they advise, give it. All of these patients will be known for the gastroenterology team, so involve them. They'll be knowing what to be given, how much steroids to be given, if it all steroids to be given, which steroid is preferred. Everything they will be knowing. They'll be knowing this patient, because this patient will be with chronic follow-up with a gastroenterologist. In ED management per se, it's just analgesia and IV fluids what we are worried about. Now let's see about liver function test. It becomes difficult to remember in which condition, what changes are there. So it's important to just go ahead with the physiology, how and bilirubin is synthesized, so that we can understand in different conditions what happens. Okay. So first, what happens? Hemoglobin. Hemoglobin breaks down into bilirubin. This bilirubin is unconjugated. Okay. This bilirubin is unconjugated. This unconjugated bilirubin goes to the liver, where liver converts this unconjugated bilirubin into conjugated bilirubin. This conjugated bilirubin is excreted into the duodenum, that is nothing in the GI tract. In the GI tract helps with food absorption of the food, metabolism of the food in the GI tract. It will be helpful. In the bile form, it is secreted. Here, some bacteria in the gut will convert this conjugated bilirubin into urobilinogen. This urobilinogen, some of it is excreted in the stools, some of it is excreted in the urine. Okay. If it is not present in the stools, it becomes pale in color. If it's getting more and more excreted in the urine, it becomes darker and darker in color. It becomes darker and darker in color if more and more urobilinogen. And if it becomes less in the stools, it becomes pale stools. Okay, this is the physiology what you need to remember. So hemoglobin is broken down into the bilirubin, which is unconjugated bilirubin. Unconjugated bilirubin, liver converts into conjugated bilirubin, which is secreted along with the other bile acids into the duodenum, helps with the digestion of the food particles. This conjugated bilirubin will be converted into urobilinogen by the gut bacteria. This urobilinogen will be excreted in the stools or in the urine, because this bilirubin has some dye activities. If it's not present in the stools, it becomes pale. If it's more in the urine, it becomes darker in color, classically known as cola color. Cola color urine will happen. So whenever we see increased bilirubin levels, it should be either because of this hemoglobin, which is produced because of breakdown of RBCs, there is increased breakdown of RBCs. When do we see increased breakdown of RBCs? It might be because of sickle cell disease. It might be because of abnormal shape of the RBCs like spirochetes, or it might be because of infection like malaria. Okay. Next thing is liver is not able to convert this unconjugated bilirubin what has come. So it might be hepatic cause, something wrong in the liver. It might be because of hepatitis, cirrhosis, or it might be Gilbert syndrome. Post-hepatic causes, there is an obstruction to the flow of the bile what is being produced. There's an obstruction, someone in the common bile duct or common hepatic duct or in a cystic duct or then duodenal pancreatic duct or where pancreatic duct and common bile duct meets up. So anywhere obstruction will result in post-hepatic increase in bilirubin. Let's see how it differentiates here. So we know hemolytic cause, hepatic and cholestatic. Hemolytic, there is increased production of non-unconjugated bilirubin, hence unconjugated bilirubin will be high. Conjugated bilirubin will be normal because liver function remains normal. It is producing normally, so there is no effect about it. Urine urobilinogen will be increased because more and more bilirubin is there, which is excreting into the gut, which converts into urobilinogen and gets excreted in the urine. Hence, the urine levels will be high. I'll talk about the enzymes later on. What about in hepat? When there is injury to the liver is not able to function at optimum. That's why it is not able to convert the unconjugated bilirubin into conjugated bilirubin. Why does unconjugated bilirubin increase? As there is an increase in unconjugated bilirubin and liver is unable to do it, convert it into conjugated bilirubin, whatever it is making, the good cells which are remaining and which are making conjugated bilirubin has to compete with unconjugated bilirubin. That is one of the reasons it increases, but exact pathophysiology, why the conjugated bilirubin also increases when the liver damage is seen, like in hepatitis, why conjugated bilirubin also increases is not very clearly understood till now. As there is more bilirubin produced, it gets secreted more into the gut, which will get converted into urobilinogen, which will get excreted in the urine. Hence, urine urobilinogen will be increased. What about cholestatic? That is an obstructive cause here we're discussing about. In obstructive cause, unconjugated bilirubin remains the normal itself. Conjugated bilirubin will increase because it is got obstructed. It can't get secreted in the GI tract. Hence, all of this will be in the serum itself. The conjugated bilirubin will remain in the serum itself. That's why the blood conjugated levels will go high. Urine urobilinogen will be less because it is not getting excreted or secreted in the gut. So it is not absorbed. So it is not converted. So no urobilinogen levels increase will be seen. Other than increase, it will be decreased. Why it will be decreased? Because nothing is getting absorbed or nothing is there in the GI tract to convert the bacteria into an urobilinogen levels. Now at the last, let's talk about the enzymes. ALT and AST are liver enzymes, we call it. These enzymes are inside the cells. If the cells break down, then these enzymes gets dispatched into the interstitial space where it gets absorbed into the intravascular space. Hence, you can see in the serum. Main enzymes are ALT and AST. As there is no damage to the hepatocytes, that is liver cells, it remains normal in hemolytic and cholestatic conditions. In hepatic conditions, it increases because of hepatitis. There is injury to the hepatocytes and these enzymes get secreted into the interstitial space and absorbed intravascularly. What about ALP and AGT? ALP is slightly non-specific. There are other conditions also where it can increase, like bone pathologies, it can increase, pancreatitis can cause increase in ALP. When there is an increase in ALP and GGT together, it is suggestive of an obstructive pathology. That is cholestatic pathology, you need to remember. So that's how you can remember. If you think the whole physiology, what I explained is very overwhelming for you, then you need to mug up everything what has been mentioned here. It's important for your practice and it's important from exam point of view also. Whenever there is an hepatocellular pattern, always get viral serology. Autoantibodies will be required. Sometimes alpha-1 antitrypsin might be required. Sometimes it might be because of abnormal deposition of copper in the liver, known as Wilson's disease. Abnormal deposition of the iron, known as hemochromatosis, can cause this. Sometimes if you're thinking it is an hepatocellular carcinoma or it is metastasis from some other place, liver is the commonest organism for metastasis, then you might have to get a liver biopsy done. Polycystic pattern of LFT. If there is an obstruction, get an ultrasound to see where is the obstruction. If ultrasound is not successful, MRCP will be required. ERCP is both diagnostic and therapeutic. Antimicrobial, antimitochondrial antibodies are required for especially for something known as PBC, which stands for primary biliary cirrhosis, where it causes and mass and obstruction in the biliary tree. So any doubts still here, you can ask me about LFTs only we have talked about here so that you understand. Mainly, I want you to understand this chart, what we have put up here.
Sir, antimicrobial antibody, once again, can you explain?
Antimicrobial antibodies is mainly for primary biliary cirrhosis. Again, it's too much in depth if you go into what is primary biliary cirrhosis. It's a mass in the biliary tract, what you're seeing. It causes an obstructive jaundice or cholestatic pattern of LFT changes.
Thank you.
Liver failure. Liver failure, we call it as an acute liver failure if encephalopathy or coagulopathy, abnormal coagulation profile, or there is some changes in the GS, altered sensorium. You see, with after or within 26 weeks of the first symptom which is presented, then we call it as an acute liver failure. If it's more than 26 weeks, then we call it as a chronic liver failure, where there are chronic changes like fibrosis and sclerosis will start setting in, which are irreversible changes. Fibrosis is an irreversible change of the liver. Causes of acute failure. There are plenty of causes for acute failure. The importance of toxins which can cause HELP syndrome, commonly seen in pregnant ladies due to preeclampsia complications. HELP syndrome can be seen, where it stands for hemolysis, elevated liver enzymes, and low platelet counts. Is a HELP syndrome. Toxins are one of the important things. Malignancy. It can be in primary malignancy like hepatocellular carcinoma, or it can be in metastasis. So there are various causes for liver diseases. How do they present? They present by has an hepatic encephalopathy that is altered sensorium. Initially, grade 1, we call it only if they are drowsy or some changes in the mood. Grade 2 is when they are confused at times and their behavior becomes inappropriate, like defecation in a public place. That kind of inappropriate behavior will start starting in. Grade 3 is when they become very stuporous. That means they're responding only for painful stimulus. They're very confused, grossly disoriented they are. 4 is when they are unresponsive or they are in the coma. They can have jaundice like this. They can have fetor hepaticus, that is nothing but bad smell. They can present with ascites, upper recordant pain, astrax. This is when you ask them to extend at the wrist level. That is dorsal flexion. They'll be having flapping tremors. These flapping tremors are known as asterix. They'll be having constructional apraxia. That means if you draw something, they may not be able to draw similarly. It will look more haphazardly in an adult patients. These are the features of acute liver failure. Again, they develop over and longer time, and that's the reason it's not important from emergency point of view. What are the complications? Patient presenting with the complications are important. They can present with cerebral edema, renal failure, recurrent episodes of hypoglycemia, coagulopathies. Why coagulopathy? Why hypoglycemia? Okay. Why renal failure? Why cerebral edema? This is mainly because proteins are synthesized in the liver. That's the reason it is required. Whenever there is depletion of glucose levels, gluconeogenesis and glucagons mainly act in the liver and they produce more glucose levels. That's why they'll have recurrent episodes of hypoglycemia. Clotting factors. Clotting factors. Most of the clotting factors are synthesized in the liver. If liver is affected, there will be coagulopathies. Management. You go according to airway, breathing, circulation. If something is abnormal, you treat them. You make sure the ammonia levels are low by making sure you empty the bowels by giving enema. Either you can give lactose or phosphate enemas and empty the bowel. If there is an associated renal failure as a complication, hemodialysis will be required. If you think paracetamol overdose is causing this, N-acetylcysteine might be required. Important thing to remember is whenever the patient is in liver failure, that is acute liver failure, avoid sedative drugs. Avoid the drugs which are metabolized in the liver. Avoid diuretics which causes hypokalemia or the drugs which causes constipation. We don't want them to be constipated. We don't want any drugs which are metabolized in the liver to be given. We don't want any sedatives to be given, because one of the complications here we have seen is hepatic encephalopathy. If you give sedatives, GCS can drastically fall, resulting in compromise of the airway, and intubation might be required. Liver sclerosis. Liver sclerosis is basically the liver parenchyma is getting converted into fibrosis because of a chronic insult. Chronic insult most of the time will be alcohol. From exam point of view, you're thinking about alcohol. Again, they can present with various symptoms like spironavy. They can present leukonychia. They can present with clubbing. They can present with splenomegaly, gynecomastia, parotid gland enlargements, palmar erythemas, that is nothing but redness of the palms, they can present with. Okay, the various features they can present with. Again, these features are not important. The complications of chronic liver disease are important. Like portal hypertension. Portal hypertension main complication is upper GI bleed. We have already learned how to deal with an upper GI bleed. This portal hypertension causes variceal bleed, which causes upper GI bleed. Can produce with ascites, that is accumulation of fluid in the tummy. If it is a gross ascites, then it is a problematic because it starts compressing over the diaphragm. The breathing will be hampered. If this ascites gets infected, then we call it as a spontaneous bacterial peritonitis, which we'll be discussing in the next slide. It is important. It can affect your CNS symptoms, especially if the ammonia levels go high. Hepatic encephalopathy can happen. It can cause renal failure, which is known as hepatorenal syndrome. They causes increased incidences, or it is a risk factor for hepatocellular carcinoma. As I told you, spontaneous bacterial peritonitis is important. This is important because any patient with a gross ascites presents to the emergency department with fever or abdominal pain, always think of spontaneous bacterial peritonitis. How do we diagnose these patients? Get an ascitic fluid and test it. For WBC counts are more than 1,000, then yes, it's a spontaneous bacterial. Or neutrophil count is more than 250, then spontaneous bacterial peritonitis. Or if you're able to isolate an bacteria, most common is E. coli. If you're able to isolate this by doing a gram staining, then yes, it is a spontaneous bacterial peritonitis. Usually we'll be giving third generation cephalosporins like cefotaxime or ceftriaxone. IV albumin reduces the morbidity and mortality and renal failure. So every patient gets an IV albumin. If ascitic fluid, if you're planning to tap, don't tap it more than 2.5 liters. That's the maximum you can tap in a single setting. Similarly, pleural fluids, you are doing tap, it's 1.5 liters. Similarly, if you're tapping air, that is a pneumothorax, like a simple pneumothorax or spontaneous pneumothorax, you want to tap it, 2.5 liters you can aspirate in a single sentence. Don't do it more than that. Next one is alcoholic ketoacidosis. This is important. Most of them think that ketoacidosis is there. I'll treat it like DKA, diabetic ketoacidosis. No. Okay, the pathophysiology you need to understand here to understand what's the treatment. As the name suggests, it is seen in alcohol who drinks binge or who drinks a lot. So you're drinking a lot. Once you drink a lot, there will be depletion of NAD and NADH. These enzymes are required for gluconeogenesis, so that gluconeogenesis will come down. If the gluconeogenesis comes down, the glucose production will come down. So the metabolism of fatty acids will result in increased level of beta hydroxybutyrate. Okay, this is nothing but a keto acid. Alcoholics, they don't take a lot of food because their appetite will be drastically reduced and they tend to vomit a lot. Poor food intake, glycogen will be utilized and eventually there will be depletion of glycogen. Once there is a depletion of glycogen, again fatty acid breakdowns will be there. Because of fatty acid breakdown, beta hydroxybutyrate is produced. Beta hydroxybutyrate is important here. Because of alcohol ingestion and poor food intake, they are in a stressful and dehydrated condition. This will stimulate the counter-regulatory hormones, especially the corticosteroids, glucagon, increased glucagon levels and decreased insulin levels. All this again will stimulate fatty acids breakdown, will cause increased level of beta hydroxybutyrate. Accumulation of ketone bodies will result in metabolic acidosis in this case. This is known as alcoholic ketoacidosis. You must have observed everywhere I am saying that there is reduced glucose level because of this. That's why fatty acid breakdown. Reduced level of glucose, fatty acid breakdown. So basic pathology here, what you need to remember is reduced glucose levels result in breakdown of fatty acids. Breakdown of fatty acids will result in ketones, accumulation of ketones. This results in metabolic acidosis. This is the important pathophysiology, what you need to remember. The first part is reduced glucose levels. For the treatment, that's why you are giving glucose. So the preferred fluid, what you need to give in patients who presents with alcoholic ketoacidosis, is giving DNS, that is 5% dextrose in normal saline. Here, you're not giving insulin or anything of a DKA treatment. You're just giving glucose for this patient. Give 5% dextrose in normal saline. This patient will be fine because the pathophysiology is reduced production of glucose. That is very important here. Again, we're talking about alcohol. We'll talk a little bit about Wernicke's encephalopathy. They classically presents with a triad. What is the triad of Wernicke's encephalopathy? There is a confusion. There is an ataxia. So they're not able to walk properly. Ataxia is there. And ophthalmoplegia is there. Okay. That is restricted eye movements are there. Ophthalmoplegia, ataxia, and confusion is the triad what they present with. What is Korsakoff psychosis? This is different from Wernicke's encephalopathy. It's a more advanced stage of Wernicke's encephalopathy. You can call it as here. Okay, they will have an amnesia. It's a both retrograde and anterograde. Anterograde, he is not able to form any new memories. Retrograde, he is not able to remember what has previously happened. So he has both kinds of amnesia. Along with it, the pathognomic feature, what you remember for Korsakoff psychosis is confabulation. What is confabulation? Here, when you ask a question, the patient will reply you back. But what he's replying you back is a false answer. It's a wrong answer what he's replying you back. But patient thinks it's a right answer itself. Okay. If you ask him, what did you have in your breakfast? He will say, I had a sandwich. Though he didn't had a sandwich at all, he just had an omelette. He'll say, I had a sandwich. But patient here always, he's not trying to say anything wrong, or he's not trying to lie. He's actually not able to make out. He still thinks that he has taken the sandwich itself, though he has taken omelette. Okay, it's not purposefully he's doing. It is an involuntary thing what is happening. He firmly believes what he's saying is correct, though it is wrong. That is known as confabulation. It is classic pathognomic feature of Korsakoff syndrome. Treatment for both remains parenteral thiamine you will be giving before you're giving any glucose, because this will worsen if you're thinking about it. So any alcoholic patients, if you're planning to give fluids, always give thiamine before you give dextrose. That's why normal saline is preferred for resuscitation. Once you're resuscitating, always along with it, give thiamine. After that, if they're hypoglycemic, you can give dextrose. Never give dextrose before giving thiamine in these individuals. Before we go into a biliary tract, more often surgical emergencies, if you have any questions, you can ask me now.
Dr. Amin?
Yes, please.
Yes. These two syndrome, Wernicke's encephalopathy and conflict psychosis, it is the same one? This is advanced from this one, or everyone different?
It's slightly different. It's more of an psychosis. There's more of an encephalopathy. Wernicke's encephalopathy is more reversible. Korsakoff is not reversible, but both of them are caused because of alcohol consumption, increased alcohol consumptions.
Thank you.
Let's see a little bit anatomy of biliary tract. This is important for us to learn the differences between different pathologies. We'll be learning about biliary colic, acute cholangitis, and then will be acute cholecystitis, cholelithiasis. So there will be confusion if you don't know the anatomy. So let's briefly see the anatomy. This is right and left hepatic duct, which combines together to form a common hepatic duct. Common hepatic duct combines with cystic duct. Cystic duct is nothing but a duct of a gallbladder. A cystic duct and a common bile duct, when they combine together, form a common bile duct. This is the common bile duct. This common bile duct joins with a pancreatic duct and excretes everything, all the enzymes and the bile juice into the gut. In the duodenum, it gets excreted. So this part is common bile duct. This is cystic duct. This is common hepatic duct. This is right and left hepatic ducts. That's what you need to remember. Let's go into the pathologies now. Biliary colic. As the name suggests, it's no inflammation or no infection is happening here. There is a stone here. Because of this stone, there is an obstruction. There is constant constriction of the gallbladder, but it is not able to secrete the juices what are present in this gallbladder into the tract, that is into the common bile duct and all. That's the reason they tend to start having pain. Okay, pain is mainly because of increased intraluminal pressure and distension of the gallbladder because of an obstruction. Most common cause of the obstruction is a gallstone. Okay, a stone is present, a stone. Most of the time, the stone gets lodged either in the cystic duct or in a common bile duct. It can be. So it can be lodged in a cystic duct or common bile duct. When they're here also, it is known as Hartmann's pouch. Here also it can get lodged in. So biliary colic is just a pain what this patient is having. So you remove the gallbladder completely, so the pain will go away. If they are very much symptomatic and this pain is very much troubling them, it is coming recurrently, then we are worried about, then we might do a surgery. Otherwise, we tend to avoid a surgery. What is acute cholecystitis? Inflammation of the gallbladder is known as acute cholecystitis. Okay, 95% of the time is due to the obstruction at the neck level of the gallbladder. So neck level, there is an obstruction. So there is stagnant bile juices that gets infected over the time, results in inflammation of the whole gallbladder itself. Only 5% of the time there will be no stone. It might be because of secondary to trauma, burns, or diabetes. Any reasons of such sort might be present. A-calculus acute cholecystitis has a poor prognosis. This one has very good prognosis when there is an obstruction because of a calculi. Prolonged obstruction may result in bladder emphysema. We'll talk about it in coming up slides. So how do they clinically present with? This clinically, usually it will be females in their 40s, they will be presenting with an upper eating lot of fatty food. So F's, female presenting in 40s, eating a lot of fatty food, 3 F's they'll present with, and they'll be associated with an right upper quadrant pain. When there is an inflammation of peritoneum, then we call it as a peritoneism. Local peritoneism results in Murphy's sign. What is Murphy's sign? When you are doing a deep palpation in and right upper quadrant and you ask him to take a deep breath and expire out, the tip of the gallbladder touches to the tips of your fingers, resulting in severe pain known as Murphy's sign. Best investigation is to get an ultrasound scan done. This is to rule out the other differential diagnosis. Pancreatitis, as it is in right upper quadrant pain, it can be an MI, it can be a right lower lobe pneumonia. Sometimes it can be a ruptured ectopic, which is irritating the diaphragm, so the pain is there. So this all investigations are to rule out the other differential diagnosis. Ultrasound is the investigation of choice to rule in cholecystitis. How do you treat these patients? First thing, you need to give an antibiotic. Third generation of cephalosporins like ceftriaxone is preferred. Once you start antibiotics, give the painkillers and admit under the surgeons. Surgeons will eventually take up foreign surgery and remove the gallbladder. What is cholelithiasis? Cholelithiasis, we call it when there is a stone in the common bile duct. Okay, or anywhere below this common bile duct. Here also, if the stone is there, then we call it as an cholelithiasis. These investigations are very much similar to that of the acute cholecystitis. The additional one, what you need to remember is an LFT. This stone has to be removed. You can't just remove the gallbladder, you'll not be able to remove this. Okay, you never remove a common bile duct. So how do you remove a common stone in a common bile duct? You need to do an ERCP, where you'll put a catheter through an oral cavity, go here and remove this stone. Either you're breaking down and basketing it in, or you're just removing it by suctioning. So any technique can be done as preferred by gastroenterologists, that is known as ERCP. When this stone or any obstruction here in the common bile duct will or might resulting in an infection which ascends upwards. That's why it is known as ascending. It ascends upwards into the hepatic ducts, common hepatic duct, and into the liver. Hence, it is known as cholangitis. Ascending cholangitis is an actual emergency. Okay, this is a life-threatening conditions. If you don't treat them, every second person dies. Mortality rate is 50%. That's why question comes on this, and it is very important. Just an obstruction without an infection is choledocholitis. Along with an obstruction, if there is an infection, then we call it as an ascending cholangitis. It presents with a classical triad, that is abdominal pain, jaundice, fever. Important, you need to remember abdominal pain, jaundice, fever. It is a very important triad. It is known as Charcot's triad. Every patient gets broad spectrum antibiotic. IV fluids will be required in this case. You need to involve the gastroenterologist, because once the obstruction is coming, first you need to remove the obstruction. Once the obstruction is removed by doing an ERCP, then surgically they will remove the gallbladder if required. ERCP becomes important here. They need to do it at a sooner basis. It's not an emergency basis, but it's an urgent basis what you're doing it. Antibiotics are very important. So what kind of antibiotics do we give? We usually tend to give a broader spectrum of antibiotics like piperacillin, tazobactam in these conditions. Let's summarize everything. If a stone is there at the neck of the gallbladder and causing only pain, then we call it as a biliary colic. If it has resulted in inflammation and infection of the gallbladder, then we call it as an acute cholecystitis. If only stone is present in a common bile duct, then we call it as an choledocholitis. If this obstruction is causing an ascending infection into the biliary tree, then we call it as an ascending cholangitis. Ascending cholangitis classically presents with fever, jaundice, and right upper quadrant pain. This is known as Charcot triad. So this summarizes the biliary tree's pathologies what we have discussed so far. Now let's go ahead and see obstructive jaundice. We have studied about obstructive jaundice, but few important things we have again put up here. Okay, most commonest cause is an gallstone, which causes an post-hepatic jaundice and obstructive jaundice. Okay, sometimes it might be because of a cancer. As you can see here, it might be because, or most commonly it is because of the cancer of head of the pancreas, pancreatic cancer. Okay, there is a law there. What does this law say? Whenever there is a jaundice, and if you're able to palpate the gallbladder, jaundice is there, plus you're able to palpate the gallbladder. Okay, palpate the gallbladder. If these two are present, then it is unlikely to be an stone. Think of cancer in these patients. Okay, as it's an obstructive jaundice, they'll present with a dark color urine and pale colored stools because of urobilinogen, as discussed previously. What is gallstone ileus? When there is an inflammation of the gallbladder, so prolonged inflammation of the gallbladder, there can be a fistula formation between the duodenum and the gallbladder. Okay, when the fistula forms, the stones can get dislodged. The air what is there in the intestinal cavity can seep into the gallbladder. Okay, so gallstones can enter into the GI tract and obstruct the lumen here. So small bowel obstructions can be seen. Air can be seen in the gallbladder. That is important. Air is seen in biliary and small bowel obstruction. So what is gallstone ileus? Gallstone, it's a stone. There is a fistula which is formed because of the chronic inflammation of the gallbladder. Once this fistula is formed, the stone gets dislodged and goes into the small bowel, and it causes obstruction in the ileum. There is an obstruction. Next thing is The air what is there in the GI tract enters into the gallbladder, enters into the biliary tree. So you are able to see the air in the biliary tree. When there is an air in the biliary tree, along with signs and features of small bowel obstruction, then we are thinking about gallstone ileus. It's a rare entity, but important entity. Here, you can't do much. You need to just do and resuscitation. IV antibiotics might be required if the patient is sick, and you need to involve the surgeons immediately. This is known as gallstone ileus. The last topic what we are studying for today is acute pancreatitis. Inflammation of pancreas is known as pancreatitis. Okay, what are the most commonest causes? The first most commonest causes is because of an gallstone which is obstructing the duct of the pancreas, resulting in inflammation of the pancreas. Second most commonest cause is alcohol consumption. Third most commonest cause is increased in triglycerides levels. Increased in triglycerides levels is the third most commonest cause for pancreatitis. How do they present? They present with a severe epigastric pain. So pain is in the epigastric region. And we all know this is a retroperitoneal organ. That's why the pain will be radiating to the back. Epigastric pain radiating to the back. Along with it, it will tell that I am not able to retain anything. Hence, there will be a lot of vomiting, nausea will be involved. The two classical signs you can see, but not commonly seen at all, is bluish discolorization around the umbilicus known as Cullen sign, bluish discolorization around the flanks known as great runner's sign. So this is a great runner's sign. This is a great runner's sign. In the flank, you can see there is a bruising kind of thing, what you can see. Around the umbilicus, it's known as Cullen sign. As I told you, most commonest cause is gallstones, followed by ethanol. The third most commonest cause is hyperlipidemia, that is high triglyceride levels. Other causes also you can remember with a mnemonic known as get smashed, where G stands for gallstone, E stands for ethanol, T stands for stroma, S stands for steroids, M stands for mumps, A stands for autoimmune antibodies, S stands for scorpion venom, H stands for hyperlipidemia, ERCP, any procedures you are doing, certain drugs like sodium valproate, triglycerides, thiazides also can cause acute pancreatitis. Investigations. Lipase is the preferred one. It's more sensitive and specific compared to that of the amylase. Neither of them can rule it out, especially if they're very acute. Enzymes might not been raised at all. If you have any confusion, if the diagnosis is doubtful, you can get a contrast enhanced CT scan. This is the latest which is coming up. You did not remember because still it is not been advised in the guidelines. Full blood counts might be required. Calcium levels are important. Coagulopathy or coagulation profile is required because coagulopathy is one of the complications of acute pancreatitis. Calcium tends to deposit on an inflamed pancreas. That's why low calcium levels can be found. Sometimes it might be a stone which is obstructing both the common bile duct as well as the pancreatic duct. So it is at this junction. So it is important to get an LFT also done. It might be associated with acute cholangitis also. LFT is mainly because to rule out acute cholangitis. Sometimes there might be an acute cholangitis associated with pancreatitis. There are various scorings which are there which predicts the mortality, like Ranzer's criteria. Another one scoring is there, Glasgow prognostic criteria. There are plenty of scorings. If you ask me, is it required to remember? No, because they're quite complicated. It is not humanly possible to remember it at calcium level of this much or urea level of this much, base excess of this much, and remember the scores, remember the values. It's not possible. So we don't recommend, we only recommend you to remember the names. At least remember the two names. They are, at least remember that there is a criteria which helps to predict the prognosis of the disease. That much should be more than enough for exam point of view. What do we do for the treatment here? Most of the time, it's a symptomatic treatment. If he's not able to retain fluids, then we are giving IV fluids for this patient. If they are shocked, we might have to give the resuscitation. So we'll go any compromise with airway and breathing, we're not suspecting. If at all, if it's there, we'll intervene. In circulation, they might be in the shock. There is tachycardia, hypotension, increased CRD, then resuscitate with IV fluids. Okay, if they have, then we are coming to a symptomatic treatment. If they are vomiting, give antiemetics. Nasogastric tube will be helpful with the vomiting. Okay, Pain management, that is analgesias, are very important. Most of the time you will be requiring opioid because there will be an acute severe pain. Don't give anything by mouth because they will tend to vomit everything. So keep them nil by oral. Urinary catheterization might be helpful to monitor the urine output to see whether this patient is dehydrated, how much urine output is there. Because of dehydration, they're not setting in into AK or not. So close monitoring of the urine output is important. It's not advised for every pancreatitic patient to be on antibiotics. If they are in sepsis, anything which is suggestive of in sepsis because there is a source of infection, sepsis is there, you're thinking, then give IV antibiotics. As in prophylactic, it is not recommended. No prophylactic antibiotics are recommended in pancreatitis. Okay, admit all patients whom you're suspecting or diagnosed as pancreatitis. Don't discharge anyone. The role of proton pump inhibitors or H2 antagonists are not clear. More research is required. As of now, we don't recommend giving an omeprazole or pantoprazole or anything, any those class of drugs. That is, proton pump inhibitors are not recommended to be given in acute pancreatitis. Same thing holds good for H2 antagonist also. Like ranitidine is not advised to be given. There is no literature to suggest or support their helpfulness in an acute pancreatic patient. Anyone has any questions, you can ask me before we go ahead with the question and answer session. Anything about the gallbladder, inflammation of the gallbladder, acute cholangitis, any questions are there, you can ask me, or acute pancreatitis, you can ask me before we go ahead into the question and answer session.
Dr. Amin?
Yes, please.
Can you please explain again the causes of acute pancreatitis and most common one?
Gallstone is the first one. Okay, alcohol consumption is the next one. The third one is high triglyceride levels. Okay, these are the three most commonest one what you need to remember. Rest you can remember with a mnemonic known as get smashed. Okay, which other are, but these are the three most important one. First most commonest, second and third most commonest cause for acute pancreatitis.
Dr. Amin, hypercalcemia can cause pancreatitis?
There are certain causes can trigger pancreatitis as mentioned here. Okay, hyperglycemia I have not come across as a cause for acute pancreatitis. These are the causes which we are more familiar with causing. Hyperglycemia I have not come across causing pancreatitis.
Hypercalcemia. I mean hypercalcemia, not hyperglycemia.
Hypercalcemia. I'm not come across with hypercalcemia also. Okay, let's go with the question and answer session now. These are the recall questions what we're discussing now. We have a 43 years old gentleman who has a presented with 1 day history of fresh hematemesis. He had 3 to 4 episodes, each consisting of a full mug of fresh blood. He is an alcohol dependent with a documented alcoholic sclerosis and known to hepatologist. Observations include a respiratory rate of 24 breaths per minute, saturation is 95 in a room air, heart rate is 116, blood pressure is slightly on the lower side. He is 85 kgs and blood results are as given below here. These are the blood results. Hemoglobin is slightly on the lower side, WBCs are fine, platelets are also on the lower side, lactate and glucose, everything is being given. Which one of the following initial fluids is the most appropriate for this patient?
500 to 1000, 0.9 saline. D.
D is the right answer here. Why not Hartmann's? Isotonic fluids like Hartmann's. Yes, please.
No, it's
contain potassium.
It's okay. It contains potassium. Why are you worried in this case that potassium will be increased?
Also, liver disease.
Contraindication to give Hartmann's fluid is whenever there is a liver disease, we usually don't use or don't prefer giving Hartmann's fluid. Okay. We also don't give it whenever we are suspecting an high potassium levels. Whenever we are suspecting an high potassium level or liver disease, Hartmann's is not given. Other than these two conditions, wherever you are doing a fluid resuscitation, Hartmann is the preferred one, more preferred than the saline. Okay, we'll be talking about it, why it is more preferred infectious diseases during the fluid resuscitation. But remember that whenever you give a lot of fluids, it can cause hypercholemic metabolic acidosis when you give normal saline. That's a very common complications when you resuscitate with giving a normal saline. That's why they are more and more recommending for you to resuscitate a patient who is hypotensive with Hartmann's fluid. Hartmann is very close to ringer lactate. It's almost similar to the ringer lactate.
Doctor, why is contraindication in liver patient?
It interferes with the lactate. So lactates can increase because of Hartmann's. Okay, when there is a liver disease, this lactate, what is produced is different from the lactic acid which is produced in the sepsis. Okay, because the lactate levels are high. Here, Hartmann's also contains some amount of lactate. This lactate is not similar to the liver disease. Because of the liver disease, we are not giving, because Hartmann's has some amount of lactate which tends to accumulate if there is a liver disease. That's why it is contraindicated.
Why first
Doctor,
answer one?
doctor, in the option, if there is a dextrose, the same dose 500 to 1000 مثلا DNS or
DNS is never
still
preferred. Only crystalloids, colloids. DNS is an colloid.
Lower side.
Colloids,
Also lower side.
whatever, however lower it is, colloid is not preferred fluid for resuscitation. Never give N colloid. You will be always wrong if you give N colloid. Always you need to give crystalloids. Ideally, isotonic crystalloids are the preferred one. One of the crystalloids is normal saline. Other crystalloids is ringer lactate, or also known as Hartmann's. This is the more preferred one compared to the NS in most of the situation, except in liver diseases and high potassium levels. Never give colloid. DNS is in colloid. Don't give DNS.
Sir, why can't we first answer, sir? 20 ml per kg normal saline?
We usually don't give 20 ml. It is a large amount of. We are always giving small boluses for resuscitation. That is 500 to 100 ml, 500 to 1 liter of fluid. What is recommended to be given? If it is in situations where you are suspecting there might be a fluid overload, like a person with a heart failure, then we'll be giving small boluses of 250 to 500 ml. The bolus volume will be reduced. Those are the latest recommendations for fluid resuscitation. Not according to the kgs we are not giving, because this itself will be a large amount of fluid what you are giving. For example, he is an 85 kgs, so 85 into 20 will be a large amount of fluid for this patient. Okay, so it will go around, if I'm not wrong, 1700 ml. It's a large amount. We don't want to give large amount. We give small boluses and see whether the patient is responsive or not. If not responsive, then we'll plan to give more boluses till the IVC is distended, or there are any clinical signs and features which is suggestive of fluid overload.
Okay, sir, thanks.
We have an 87 years old.
Ameen, sorry.
Yes, please.
Last question. There is if there is blood, can we give blood for this patient?
Yes. If blood is there, then start with blood transfusion immediately. For example, if this question itself had one more option here saying PRBC, then start with PRBC, because blood transfusion, because it's an hemorrhage, what is happening, then give blood. Blood is the best one. We have an 87 years old woman from a residential home with a 2 days history of diarrhea. She has had 10 episodes of watery diarrhea, but no vomiting. She complains of colic abdominal pain. She had a 5 days course of antibiotics for a chest infection 2 weeks back, but she cannot remember what they called. Observation shows a respiratory rate of 18, saturations is normal, heart rate is normal, blood pressure is in the normal range, slightly higher side. Temperature is normal, and blood pressure is PM, that is blood glucose level is 5.6. Examination reveals that her abdomen is sore, but there is generalized tenderness, especially across the lower abdomen. What is the most likely causative organism? What is the most likely diagnosis?
Clostridium.
Insulin breathing.
Option 4.
With this
Antibiotic.
long history, you need to remember that whenever they mention a history of antibiotics, Clostridium difficile should be first differential diagnosis you need to think about. The treatment for Clostridium difficile?
Vancomycin
Metronidazole.
Both are given per orally. These are the preferred treatment. Metronidazole was given previously. Nowadays, they don't recommend it. This is vancomycin acts much better and fluoxetine acts much better compared to metronidazole. Patient presents to the ED with an upper GI bleed. You are calculating a Blatchford score. Which one of the following is included? Is there included? They are asking.
liver disease.
Liver disease is included. Age, respiratory rate, or hematemesis is not included in Blatchford score. This score is important. You need to remember. You should know in and out of Blatchford score. We have a 40-year gentleman who is a known alcoholic, has come in with vomiting of a fresh blood since the morning, multiple episodes. Says might have lost around 500 ml of blood. Heart rate is 101, blood pressure is 100/70, saturations are normal, respiratory is 20 beats per minute, 20 breaths per minute. You are suspecting a vessel bleed. Which drug is known to reduce the mortality in vessel bleed? Terlipressin is the only drug which is known to reduce morbidity as well as mortality in upper GI bleed caused by varicose bleeding. Elderly patient presents with complaints of blood in the vomit. You decide to use Glasgow Glatchford score. Which one of the following is not included in the scoring? It's not included. Hemoglobin, urea, and blood pressure is included. Age is not included. Blatchford score is associated with which one of the following?
Liver disease.
Liver disease.
Liver disease is the right one here.
Dr. Amin, Glasgow is also important for memorization.
Yes, you need to memorize this. Otherwise, definitely one question will appear. You lose that question. You need to memorize the components. Values are not important. The components are very important. Blatchford score is very important from exam point of view. You need to memorize everything. We have a 35 years old came to the ED with sweating, tremors, and agitation. He is an alcohol dependent. His last drink was 36 hours ago, and his blood pressure is in normal range. The slight tachycardia, saturations are normal, GCS is normal. Blood glucose is 3.9, slightly on the lower side. What's the next step in the management? This we have not this we have not discussed. This patient is basically having an alcohol withdrawal.
Diazepam, agitating.
diazepam.
Yeah.
We will discuss about alcohol withdrawals in our psychiatric chapter while we are discussing. The right answer here is diazepam. The diagnosis here is alcohol withdrawal. All the symptoms are all of alcohol withdrawal. He's a chronic alcoholic and he didn't have alcohol for 36 hours. So first you need to treat the alcohol withdrawal. He's agitated, he's having sweating, tremors, give diazepam. Then you can think of thiamine and all here. Okay, it's not an emergency. Diazepam is an emergency to be given. Again, we'll discuss a same question again in a psychiatric chapter. Young female came back from a trip to Morocco. Complaints of bloody diarrhea since then. On examination, abdomen is soft, non-tender, no guarding, and no rigidity. Most appropriate investigation in this patient. So what
routine for ovaries.
Option 5.
There is an travel history. Along with the travel history, there is an dysentery. There is bloody diarrhea, dysentery. Always think about an parasitic infection. Okay, that's the reason you are getting a stool for ova and cyst, because you're thinking about parasitic infection. Of 40 years.
What's about the treatment? Metronidazole?
Yeah, usually we go, if it comes positive, then we go ahead with metronidazole or tinidazole. We can go ahead. A 40-year-old female presented to the ED with complaints of right upper quadrant pain. On examination, the patient is febrile and eccritic, most likely organism. What's the most diagnosis here?
Cholangitis.
Acute
cholangitis. Descending cholangitis.
Ascending cholangitis is the right answer here. There is a triad, that is right upper quadrant pain, icterus and febrile. It's a Charcot triad is there. Charcot triad suggestive of acute cholangitis, ascending cholangitis, sorry. Ascending cholangitis. Most of the infections in abdomen is caused by E. coli. Most common organism here is the E. coli. Most of the most common for spontaneous bacterial peritonitis also it's E. coli. For acute cholangitis also E. coli. Acute cholecystitis also E. coli. Okay, so E. coli for abdomen organ infection you can remember. A 24 years old male came to the ED with his partner. Complaints of generalized weakness with nausea and a deep jaundice, abdominal pain, mainly in the right upper quadrant. His vitals are stable. The liver enzymes are elevated. What is the probable diagnosis here?
Hepatitis viral.
Hepatitis B virus.
Viral.
Viral infection, what we are suspecting here. Why not cholecystitis?
Because he's
Fever. Infection.
Cholecystitis fever can be seen in cholecystitis also. Upper quadrant pain can also be seen in cholecystitis, but we don't see jaundice in cholecystitis. Okay, we see in hepatitis. Yes, hepatitis, viral hepatitis. Yes, we see jaundice. Both conjugated and unconjugated bilirubin levels will be high. Biliary colic is just a pain. It doesn't causes any abnormalities. I mean, it presents with abdominal pain, but it doesn't present with any fever or jaundice. Will not be there. Gilbert syndrome is a congenital abnormality. Its presentation is not like that. Gilbert syndrome, there is a deficiency of enzyme which prevents the conversion of unconjugated bilirubin to conjugated bilirubin. It's a congenital abnormality. They'll not test you on Gilbert syndrome. Okay. Cholecystitis, because jaundice is there, we have ruled out. Because fever and jaundice there, biliary colic is ruled out. It's a congenital abnormality. This is an acute setting. So hepatitis is the most likely answer here.
If obstructive or complicated by infection, you can see jaundice and fever also, sir.
If it is complex, sorry.
If it is obstructive cholecystitis.
In obstructive cholecystitis, you never see an jaundice. If you're seeing a jaundice plus fever plus right upper quadrant pain, it should be acute cholangitis. It's a Charcot triad what you're looking out for here. Charcot triad is not at all given here. Okay, this is Charcot triad.
Which investigation? In this question, which investigation, if they ask, we will do?
We will be getting enzymes. We'll be getting markers, that is the antigens levels for hepatitis B. You will be checking for hepatitis A. You will be checking for. Most likely, it is an hepatitis A infection what this patient is presented with. We are suspecting because of vomiting, abdominal pain is a young individual, might have had anything outside that might have fecal oral transmission is hepatitis A. So you will be getting an investigation that is viral serology directed towards hepatitis A. Basically, viral serology of hepatitis A and B will be required in this patient.
Dr. Amin, hepatitis is important to read for exam.
You just need to know hepatitis, what it causes. More than that is not required. Hepatitis causes both increase in conjugated and unconjugated bilirubin levels. Okay, and as it's an inflammation, it can cause fever and pain. That much, if you remember, that should be sufficient.
Doctor,
and the
this
enzyme
patient
levels will be very high.
This patient not have fever, sir? If he have fever, this would be ascending cholangitis.
In
in this case,
then we go ahead with ascending cholangitis. Okay, jaundice and abdominal pain only. We're thinking of only viral hepatitis. Sometimes they might present with fever. If fever is there, very low grade. Again, how to differentiate an ascending cholangitis from that of an hepatitis? Hepatitis and ascending cholangitis. Okay, when you get an AST and ALT levels, this will be very high in hepatitis. It will be only slightly high. Very high in the sense it will be in thousands. Okay, the value will be in thousands. Here it will be in hundreds in ascending cholangitis. In acute hepatitis, it will be in thousands. That will help you differentiate it.
But there is no other in the history different between the hepatitis.
Fever is more commonly seen in acute cholangitis. Fever is not commonly seen in hepatitis.
Okay.
Both will have jaundice. Both will have abdominal pain. We have an young female came to the ED with fever, vomiting, and abdominal pain. On examination, our right upper quadrant is tender and there is icterus. What is the most probable diagnosis here?
Acute cholangitis.
Option 2,
Cholangitis.
ascending cholangitis. So from here, you need to remember that ascending cholangitis is very important. They tend to ask questions on ascending cholangitis and Blatchford coma score for upper GI bleed and management of upper GI bleed. These are the 3 hot topics from gastroenterology where there will be extensive testing. That doesn't mean what we have covered is not important. Other things are also important. Where it is not important, as specifically mentioned, you can skip those spots. For example, a prognostic like in scoring, Ranson scoring in acute pancreatitis, you can just remember the name. The scoring part is not required.
Doctor, he can say in the question, he not mention jaundice and say the patient complaining of itching and fever and right upper quadrant pain.
See, if there is no charcoal thread, it's difficult to say it is acute cholangitis unless there is dearrangement of LFT. So LFT becomes an important diagnosis at that point of time.
Sir, how do you differentiate between cholangitis and cholecystitis?
LFT will not be dearranged in acute cholecystitis. Along with it, there will be no jaundice also. On examination, there will be no icterus or jaundice. LFT, when you get it done, it will be normal in acute cholecystitis.
Okay, normal LFT, no jaundice.
Yes. Again, normal LFT itself says that there is no jaundice because LFT, when you're getting, bilirubin levels will be high. And there will be high AST, slightly high AST and ALT levels also will be seen in acute cholangitis. I mean, ascending cholangitis.
Sure, sure.
Any questions anyone has, you can ask me.
Doctor, I mean, regarding hepatitis, acute and chronic investigations, it's important or not?
Chronic, you are not worried about, they'll never present to the emergency department. You'll just refer to acute. You just have to remember that, as I told you, AST and ALT will be in thousands. Okay, it will be in thousands. They'll be having some amount of jaundice for sure. Okay, and usually there will be history for hepatitis A. There will be history of outside food consumption because it's a fecal-oral route. Outside food consumption, or there might be a travel history might be there. For hepatitis B, risky sexual activities. For example, he might be a sexual worker, or he had a sexual intercourse with a sex worker, or any blood transfusions recently he has undergone. Okay, this much if you remember, it's enough for hepatitis. We're only worried about acute hepatitis. We're not worried about chronic hepatitis because it's not an emergency.
Sir, can I ask you?
Yes, please.
Yeah, sir. Alcoholic ketoacidosis, what type of a ABG will be appear?
Metabolic acidosis. Ketones are there, metabolic acidosis will be seen.
And the base excess?
In every metabolic acidosis, what do you accept the base excess to be?
Minus. Then what about the electrolytes, potassium?
Electrolytes, why are you expecting an electrolyte to be abnormal? There might be electrolyte abnormalities, but again, it's because of an acidosis you are suspecting, not because of an not because of an alcoholic ketoacidosis as such. Because of metabolic acidosis, as discussed earlier, it's an acidosis. So there might be an exchange of hydrogen ion to the potassium ion. So increase in potassium levels you can see because of an acidosis. Sodium levels will not affect.
Same as ketoacidosis, metabolic acidosis, diabetic ketoacidosis, same changes will occur?
Complication wise, because of a metabolic acidosis, same changes will be there. There are other changes which will happen because of increased osmolality of the blood because of presence of glucose. That is completely different. That is only for decay. We are only talking about metabolic acidosis. It can cause hyperkalemia. Other changes are not seen. They are specific for decay. They happen because of increased osmolality of the blood. because of presence of glucose. So glucose, there is no glucose at all here. So there is a different pathophysiology what is going on in alcoholic ketoacidosis.
Thank you.
Dr. Amin, do we need to be aware of all the prognostication and acute pancreatitis? So
No,
many
not
scoring
required.
systems were there. We need to be aware of all of them.
No voice.
No voice.
Dr. Amin, there is no voice.
If no one has a question, your lesson is already finished.